Assalamu alaikum, Dr. Uzefa.
Yes, Prof.
Yeah, Gida, yeah. The
Alhamdulillah,
family, how
sir.
is the family?
Alhamdulillah, sir. Sorry, sir. I can hear you, sir.
Okay, okay. Hope all,
You may
everyone is
begin. I've
good.
already given you admin privileges,
Okay,
sir.
okay. All right, all right. Thank you for that. Thank you. Okay. Okay. So can you see my slides? Can you see my slides?
Yes, sir. Yes, we can see the slide, sir.
Okay, good afternoon, everyone. Good afternoon, everyone.
Good afternoon, sir.
So first of all, I would like to recognize the Nigeria Society of Physiotherapy, Kano State Branch, for identifying me and giving me the opportunity not only to present today on mobility and transfer training instructions, and also to spearhead the affairs of the neuro rehabilitation interest group of the Nigeria Society of Physiotherapy, Kano State. So I feel honored and respected by the Nigeria Society of Physiotherapy, Kano State. And to the teaming participants, despite their tight schedules, so I greet each and every one of you. So my topic of presentation today is mobility and transfer training in stroke survivors. So this is the outline of the presentation for today. We have the learning objectives, introduction, risk factors for stroke, epidemiology, etiology, motor and sensory deficits that follow or that are related with mobility and transfer. Of course, we are going to see barriers to mobility in stroke patients, mobility and transfer problems after a stroke, and then the rest of the other points. So these are the learning objectives. At the end of this presentation, we are supposed to identify and be able to assess the different deficits that are associated with stroke. And we should be able to show an effective and safe method that we can do to our stroke patients to help them for their daily life activities. And we should be able to develop patient-centered transfer training methods. And we should also educate our patients and their caregivers, and as well as the families, because they are also important in the care of our patients. So as we all know that stroke is one of the debilitating and devastating conditions that, is a neurological condition, and it causes disability and death globally. So when there is stroke, then it leads to affectation or weakness or loss of function on the one side that's talking about the affected sides. So this automatically results in the stroke patients needing some assistance from either the family or from caregivers, because the activities of daily living are being hampered due to the stroke affectation. So what we normally see in stroke patients is the motor weakness, which is the major challenge seen in the stroke patients. So it is the leading cause of reduced activities in such patients. And we all know that coupled with the care that is being associated with such condition, a lot of economic involvement is attributed in the management of stroke patients. So this pave way for economic and social burdens that are associated with the stroke. So working after stroke is normally limited by gait and balance affectation. So we all know that, especially the neuro working group, all know that after a stroke, then a lot of manifestation used to appear on our patients. So even the patients that at the chronic stage, we tend to see a higher risk of fall in such category of patients. So essence of post-stroke rehabilitation should be tailored towards safe ambulation in this group of individuals, so that as much as possible, we tend to improve upon their posture, stability, and then we enhance their gait patterns. So almost 50% of stroke victims, they tend to have various forms of somatosensory affectation, which normally affects them in their daily life activities. So this kind of affectation or impairment is normally seen in almost 50-something% of these stroke survivors. So this somatosensory impairments, it can have an adverse effect on the motor outcomes in such as stroke patients. So this will limit them from participation in their daily life activities, maybe participating in community meetings, house shows, and other activities that they were doing initially. So this an image that is showing the sensory system that is involved in entirely information integration, interpretation, and then execution. We all know that we need our vision, and then we need the corticospinal tract, we need the sensory system. That is the corticospinal tract that's talking about the higher center. We see, and then the somatosensory system, it tends to take the information towards the higher center, and then the information will be processed and be sent back, and then we execute a task or a movement. So after a stroke, then there is affectation of balance and mobility. So it can affect, like I have mentioned earlier, social participation within such individuals. So stroke does not stop on only affecting the mobility, it affects communication, especially when it involves maybe some other part of the brain. Then you see communication impairment, and when it affects maybe the parietal lobe, we see affectation in cognition. We see our patients cannot be able to make decisions, they cannot be able to make calculation, and they cannot be able to perform executive functioning. So these are all other affectations that we can see as presentation of the brain insults. So these patients, they are normally, their mobility is being restricted, and they tend to present with other problems that are related to the walking. So going into the risk factors that are associated with stroke, we all know that we have the controllable risk factors, otherwise known as the modifiable risk factors. These factors, they contribute the major aspect of the stroke occurrence. We have them coming as hypertension, smoking, not even only smoking. If you are a second-hand smoker, you can be able to have a risk factor for another stroke. We see diabetes mellitus increasing our risk and pushing us towards having a stroke. We have high levels of cholesterol, which cause affectation in the lumen of the blood vessels, especially the arteries. We have physical inactivity, maybe due to the sedentary lifestyle, we eat and we only sleep, and then we tend to develop obesity. So these two factors, they are associated with maybe the occurrence of high blood pressure, diabetes. And if you have this, then you are much more prone to developing a stroke. So we have poor diet, especially diet that is high in sodium and low in potassium, and then the diet may be rich in saturated fat and sugar. So all this will push one to, will serve as a risk factor for stroke. Of course, when there is excessive ingestion of alcohol, that is another contributory risk factor that can predispose one to have a stroke. We have sleep apnea, which in case it can also increase our chances of having a stroke. We have also the non-modifiable risk factors. So these ones we cannot, from the name, we cannot be able to change or alter them. For instance, we have the age, which maybe if you are aging with advancing age, you are becoming more prone to having stroke. We have a family history when there is a lineage of stroke in the family, and one is bound to have maybe a stroke in the later life. We have race and ethnicity, which play a significant role in the occurrence of stroke. So based on the race and ethnicity, it is shown that the Afro-Americans, they tend to have higher risk in stroke when you compare them with the Hispanic descent. So we have atrial fibrillation, which is also another non-modifiable risk factor for stroke due to the abnormal rhythm that is occurring within the heart. So based on the stroke epidemiology, it has been reported that stroke is the second leading cause of global death, with 5.5 million deaths being recorded annually. So this is being reported by DONCO in 2018. Based on the GBD study that's talking about the global burden of diseases that was conducted in 2019, there were 12.2 million new cases of stroke globally. So this is alarming. To say that every year you have maybe new cases, that's talking about the incidence of 12.2 million new cases of stroke worldwide. So this is alarming, and this study was conducted in 2019. So nobody knows what happened after this study. And we have 101 million prevalence of stroke. So out of which this number that we have seen with the prevalence of 101 million, the bulk of this occurrence of this stroke happens to be in the African region. And it bears almost 90% of the burden of stroke is seen in Africa. Maybe due to a lot of factors that come into play that is happening in the African region. So going down into the Nigerian context, the prevalence of stroke is estimated to be 0.36 in Sokoto to 13.31 in the Niger Delta. This is talking about in a group of 1,000 individuals. And the reports continue to say that the ischemic form of stroke is much more common. And this is being backed up by the literature also. The hemorrhagic one constitutes 36 to 41% of the total strokes seen within in Nigeria. And then mortality was about 22 to 46% of all the stroke cases seen. So this is also a study that has been conducted by Aderinto last year. So this is a recent literature that is talking about the epidemiology of stroke in the Nigerian context. So the etiology, we all know that is based on either ischemia or hemorrhage. The ischemic stroke constitutes other portions, and then the hemorrhagic stroke also has other divisions. We all know that we see in various clinics. This is associated with maybe atherosclerosis or clots that are being formed within the heart. And we have the other part, which is the hemorrhagic stroke. This one constitutes the lesser number of all stroke cases being seen. So we have the motor deficits that affect mobility and transfers when there is a stroke. We have either hemiparesis or hemiplegia. We have impaired control in posture and balance. This is normally associated with maybe the cortico-reticulospinal pathways that are normally involved in the regulation and control of movement. We have abnormal muscle tone. When there is a spasticity, most especially in the anti-gravity muscles, then this affects how we move our limbs. either the upper limb or the lower limb. And it also affects how we bear weight on the affected lower limb. So this significantly hampers the individual ability to perform movements. So we have the loss of fractionated movement also, which is one of the motor deficits that affect our mobility. So this results in when there is reduction in selective motor control. So we tend to see synergistic patterns occurring when an individual tries to perform either a movement or trying to perform a transfer, maybe from chair to bed or from bed to chair. So sensory and perceptual deficits that affecting movement. We have the somatosensory loss, which is due to impairment or perception, our ability to detect to be able to be aware with the environment that we tend to find ourselves in, the ability to touch, and feel and identify objects, the ability to detect pressure within our body, and is normally seen in the contralateral affected limbs. We have the visual and perceptual affectation that follow stroke. This is the inability or the failure to recognize to the space on the opposite side of the brain lesion. So on the opposite side, that is talking about on the affected side. So this is normally seen when there is a right hemisphere stroke. We have impaired depth perception and verticality. That is the inability of the individual to maintain an erect posture. This is one of the factors that affect movement. It's also related to the vestibular system affectation. So when there is stroke, it's not only the physical impairment that we see. There are also other impairments that are abstract that we cannot be able to see with our own eyes. So maybe they are within the brain of the individuals. As such, we cannot be able to see them. So this affectation of verticality and depth perception is normally seen when there is the parietal lobe, because it's the one that is dealing with mostly the perceptions and other sensory functions. So in this case, the individual is misjudging distances. Maybe a distance that is 5 centimeter or let's say 20 centimeter, the individual will see it as 10 centimeter or will see it as 30 centimeter. So there is affectation in judging distances. You can see sometimes maybe the stroke patients might not be able to go upstairs because of this affectation in the depth perception and also the verticality. Impact on mobility and transfers. So the patient, based on transfer, may not position their weaker foot safely because sometimes there is all this sensory affectation. So sometimes the individual might forget the affected limb. And then also the individual cannot bear weight through an unstable joint because of the poor perception and other mechanoreceptors that are being affected due to the stroke. We have standing balance due to the loss of sensory feedback from the ankle and the foot. So the individual will tend to put more emphasis on the visual aspect. Why? Because the motor aspect has been affected. So the individual tend to concentrate more on the vision. And in the situation whereby you have affectation of the vision also due to the stroke, then you have a complex affectation on mobility and transfer. In that case, you have to spend much more time in the rehabilitation process of such individuals. We have other factors coming in as safety. They tend to have high risk of injury. For instance, maybe they are susceptible to have maybe burns due to the sensory affectation, shoulder subluxation due to the weakness in the muscles and the decreased tone in the muscles, because we need a normal tone to be able to keep our own joints in stable position, and we can be able to initiate movements. All these, they are function of a normal muscle tone. So impact on mobility and transfer still continues. We have the issue of assist to stand. So basically, and mostly in all these cases, they tend to have affectation. They cannot be able to bear weight, especially on the weaker extremity. So they tend to put much more weight on the normal side. And this increase the fall risk. And then you see the stroke survivors walking with an asymmetrical form of gait. So in terms of gait affectation, we see circumduction, and then mostly with stiffness in the knee joint, most especially in the affected knee joint. You tend to see also foot drop cases based on the level of the affectation. So in terms of impact on mobility, there is affectation on bed mobility. So the individuals will have a problem with maybe performing breathing exercises, and they cannot be able to roll maybe from the left side to be able to roll to the other right side and vice versa. So barriers to mobility after a stroke. We have the primary neurological impairment, which is either the weakness or the paralysis on the affected side. We have the balance and the postural control deficits. So this is another important factor to consider, because there is asymmetry in most of the stroke patients, especially when you observe their pattern of gait. They tend to bear more weight on the unaffected lower limb. And then if you look at their orientation, you look at their shoulder level, you look at the head, you'll see that the shoulder is dropping towards the unaffected side. So this one will automatically lead to less than 20% of body weight on the affected leg. So that means the individual will bear less weight on the affected leg or affected lower extremity, and that will hamper recovery. Because if you don't bear weight on the lower limb, you are not stimulating the receptors within each of the joints that are present in the lower extremity or in the upper extremity, because we should not concentrate only in the lower extremity. We need to rehabilitate also the upper extremity following stroke. So this will lead to this awareness of the affected site, and then the individual will even ignore the limbs that are on that affected site. We have barriers due to perception and cognition. So the individual cannot execute simple tasks, maybe simple mathematical calculation. If you tell the individual 2 + 2 will tell you, okay, 100, they will respond back by saying 1,000. And they cannot be able to perform executive functionings, and they cannot be able to perform decisions. So they will have problems with maybe attention, especially when there is a task, multitasking, that is involved in transfer, maybe while they are ignoring distractions. So secondary musculoskeletal and systematic complications. This come as maybe contracture that normally seen in stroke patient, spasticity, pain, osteoporosis, and the rest. We have also psychosocial and environmental factors. Maybe the floor is slippery, or there are no other objects that the individual can hold and walk within the environment, or perhaps due to the disability, maybe the environment is not well designed to suit the individuals with disability, especially maybe the stroke. So environmental factors in that situation, they contribute towards maybe the individuals with stroke having problems with either mobility or transfer. We have, based on the psychosocial aspect, we have depression, and they tend to lose motivation maybe to perform exercises, and they will have maybe fear, so that maybe they should not fall down while ambulating within the environment. We have barriers that are specific to transfer, maybe sit to stand or moving within the bed. So we should look at the tools that we can be able to assess mobility and transfer post-stroke. The first one is we have the functional ambulation category, otherwise known as the FAC. So this tool, it's normally measures working ability in the individual. So this involve the individual to perform a task. So it is a performance outcome measure. So it is normally scored from 0, 1, 2, 3, 4, up to 5. 0 means the individual is non-ambulant, and 5 is when the individual can be able to perform tasks across different terrains, maybe on uneven surfaces, maybe going up and down the stairs, and whatever terrain or obstacles that you introduce, the individual can be able to navigate the environment. So the advantages of this functional ambulation category is that it is simple. You can be able to score your patients. Maybe within 1-2 minutes, you can perform a scoring of your patients. And then the disadvantage is that it does not assess maybe speed quality. So this is one of the limitations or disadvantages of this tool. We have the 10-meter walk test, which is normally the common practice in our clinics. It assesses gait speed, which is it measures 10 meters, maybe either using the fast pace or the comfortable speed within the stroke patients. So when you have maybe completion of the 10-meter walk test in less than 0.4 meter per second, then you can categorize that individual or that stroke survivor to be an ambulator within a household. When it is greater than 0.8 meter per second, then that stroke survivor is considered to be able to go into the community, because the individual can walk in the community, can cross roads, can cross maybe bridges and other obstacles that he or she can find within the community. Maybe at point, maybe considering maybe from the baseline to the period after maybe some sessions of rehabilitation, if you have maybe a change of maybe greater than 0.56 meter per second, this change is considered to be meaningful clinically. So the advantages is that it is reliable and it can be a 10-meter walk test, and is a marker that maybe a stroke patient can be integrated back into the community. We have the 6-minute walk test. So it measures walking endurance and also the aerobic functionality within stroke survivors. So it measures normally this distance covered within 6 minutes. And then one of the advantages is that it tells you the real world of the functional capability within the individual. And then its constraints is that you need a space for the individual patient, whereby you have maybe a small clinic or small room that you are dealing with your patients, then this is one of the limitations of this 6 minutes walk test. We have the time up and go. So this tool also is a performance-based outcome measure, and you can use it maybe as outcome measure and also for intervention. So it assesses balance, function within the individual, and it can tell you also the level of fall risk within your stroke patients. So the individual normally covers a distance of 3 meters, whereby you mark it from the time the individual stands and then reaches a distance of 3 meters, come back and then sit down on the chair. So when you have a score within less than 14 seconds, so this is considered normal, especially in the older adult group. And when you have a score that is greater than 30 seconds, so this is showing you that there is low level of mobility within that individual. And it's also telling you that that individual is at risk of sustaining fall. So it is fast and excellent predictive value. And one of the constriction in this tool is that it requests some baseline mobility so that the individual should be able to walk. If a stroke survivor cannot be able to walk, then you cannot use it this time up and go. So in patients or stroke survivors that has low level of functions, also you cannot be able to use the time up and go. So we have the dynamic gait index, which measures the ability to adapt gait maybe to complex tasks. For instance, maybe you ask your stroke patient to walk while he or she is talking, or while he or she is turning maybe her head or his head maybe to the sides. Because all this turning head to either left or right, it requires maybe functionality within the neck muscles, and it requires also the writing reflex, and it requires some functions also within the individual, especially the balance function. So this dynamic index normally adapts it in such situations. It's a scale that has 8 tasks. It is normally scored from 0, 1 to 3, and it has a maximum score of 24. So when you have a score that is less than 19 out of 24, it's telling you also that your stroke survival or your patient is at the risk of maybe sustaining fall. So it is excellent for assessing high level, maybe functional level in balance, maybe while the individual is moving around. One of the disadvantages is that it requires endurance within the individual. Why? Because you are attaching it to a lot of tasks. So the individual should have good endurance so that he or she can be able to perform the task and also while walking around. So transfer assessment tools continue. We have the sitting balance and trunk control. So this serves as a baseline if you want to perform all forms of transfers, be it maybe from the bed to chair or from maybe chair to bed and vice versa. So it is normally assessed in combination with a trunk impairment scale, which normally measures coordination within the trunk, and also it assesses the dynamic and static, highly recommended in stroke survivors. We have also another tool that can be used, the sitting part of the patch balance scale. We all know that the patch balance scale has several domains, almost 14 domains within the patch balance scale. So you can incorporate the sitting aspect of the patch balance scale to assess the sitting balance. That's talking about the assessment of transfer in your stroke survival. We have the modified ranking scale. So this one, it measures the global disability and independence level within the stroke survivors. And it is heavily weighted towards mobility and transfer. So this one is more of a combination tool that you can be able to look at mobility and you can be able to look at transfer within the individual. It has a scale of 0 that indicates no symptoms, to the level of 5, telling you that there is a severe disability within your patient, or the patient is bedridden, and as such, the patient needs constant attention from maybe the rehabilitation team. The advantages are that it can be used widely in stroke trials, and then the disadvantages is that it is not a comprehensive performance measure. So it normally relies on the judgment from the either physiotherapist or from the clinician. We have the motor assessment scale. This is specific sitting balance and preparatory movement for transfers. Example, maybe if you want to scoot to the edge of bed, maybe while you are lying on, let's say lying on the bed, you want to shift your body to the edge of the bed. So this one is normally used in that aspect. The advantages is that it is well-validated stroke-specific scale, and one of the disadvantages is that it shows incomplete sensitivity, especially during the initial phases of recovery. So it cannot be applicable during such periods. We have the performance, quality, and observation. So this is coming from the physiotherapist side. We look at other domains or other aspects of the care. For instance, maybe we look at safety, maybe you make sure that there is low level of maybe fall risk. The environment should be non-slip free and should be weight and from all other obstacles or any other objects that can cause your patient to trip and then fall down. You look at also independence. Can you hear me? Hello?
You are loud and clear, sir. You are loud
So
and
we
clear.
can hear
Yes,
you.
we are following, sir.
Okay, thank you. So we have the independence. You look at if maybe your patient requires maybe an assistance, or maybe need for verbal cueing, in the sense that maybe you encourage your patient, okay, good, you've taken this distance, look at the distance that you've covered. So in that case, maybe you encourage your patient to be able to move ahead. So you look at the quality of the presentation, as talking about the posture in your patients. You look at the symmetry, you look at how efficient is the gait or the movement of the individual, and how the individual is being able to use the affected part of the body. Maybe ability to swing the hand, ability to move the leg, flex the hip, flex the knee, maybe while going upstairs, and other components of the movement. Also, you should consider the use of assistive devices. For instance, maybe the patient maybe requires the use of cane, or maybe the use of transfer boards from the bed coming to the wheelchair or coming to chair. And how the patient is being able to use maybe grab bars, maybe in the toilet, or while moving within maybe narrow terrains, or while going upstairs. So you, as clinician, you look at all this when it comes to assessing your patients for mobility and transfer. They are very, very essential. So we have the comprehensive assessment tools that combine mobility and transfer. One of them is the badge balance scale. It measures both dynamic and static balance across 14 domains of tasks or functions that are required by the stroke patients to perform. So it includes transfers, that is maybe from sitting to standing, or the other way around, maybe from standing to go back to the sitting position. The ability of your stroke patients to reach or to stand. So it has a scale that is being scored from 0 to 56. The interpretation is that if you have a score of less than 45, it's telling you that your patient is having higher risks of falling. So this is one of the most widely used assessment tool for mobility and transfer also. We have the FIM, otherwise known as the Functional Independence Measure, or the IMPAC, the Activity Measure for Acute Stroke. So it measures care burden in both cognitive and motor domains. So mobility transfer items that you look at when considering this maybe from bed to chair to wheelchair transfer. Either maybe from bed to chair to wheelchair, or going back from wheelchair to chair and then to bed. How the individual is being able to use the toilet. Maybe let's say the toilet is, let's say WC sitting one. How is the individual be able to sit comfortably on the WC? And then after use of the toilet, how is the individual be able to stand up from that WC and then move back to the wheelchair or move out of the toilet? How is the individual be able to use the shower transfer and other tubs that are seen within maybe the environment? It has a score of 1 that is telling you that maybe the patient is needing total support. And then a score of 7 is telling you that your patient is independent. The patient can perform almost all of the activities of daily living if the patient scores 7 on the film. So we have another tool that is a comprehensive one talking about the stream. So it's specific to stroke patients. It measures voluntary actions that are being performed by the stroke patients. Maybe, for instance, breathing exercises, rolling on bed, and then upper limb functioning. So it has the advantage that it is specific for stroke, and it can detect small changes in maybe functional activities or movement within your patients. And it takes a lot of time. And then maybe if the patient is having maybe cognitive impairment, so this is one of the limitations of this stream. We have the pathway for the clinical application of maybe the mobility and transfer in our stroke patients. So normally in the acute stage, sorry, let me close this. So in the acute stage, you can use the functional ambulation category. You can use the modified ranking Your focus in this one, safety and basic bed mobility, because the patient is in the acute stage. As maybe if the patient progresses, then you can begin sit to stand, maybe from the bed. The patient should be able to stand, but in this case, the patient requires maximum assistance, maybe due to the weakness, especially in the affected side. And then maybe other people can be able to stabilize the limb, maybe stabilize the joints in the affected side. So you can use also the MAS sitting items in this acute stage. So moving forward, thus your patient is improving in the inpatient rehabilitation, maybe between 1 to 6 weeks. You can be able to introduce other assessment tools. For instance, maybe the 10-meter walk test, time up and go, BBS, film, and the rest. So this one requires intensive transfer and then gait assessment. Why? Because at this stage, maybe you can expect your patient to start ambulating. And then you need the 6 minutes walk test also to assess endurance within your patient. And then you need also the TIS to assess maybe trunk balance. In the outpatient and then the community integration, this is talking about the period when the patient maybe begin to go back to work or begin to go back into his other business activities. So at this stage, you need the 10-meter walk test. In this part, you need the fast component and not the comfortable component of the patient. You need other tools like the 6-minute walk test, the dynamic net index, and then the time up and go, or your own assessment. So you can introduce your patient to uneven surfaces, because at this stage, your patient is being reintegrated back to his or her own normal previous life activities. Maybe there is community ambulation and endurance also seen at this level of the patient recovery. Oh, my goodness. So main considerations, if you want to select these assessment tools, number one is you look at the patient stage and how able is the individual to perform some activities. So you use the 6 minutes walk test. You should not be considered in a patient who is not able to stand, because if you want to do 6-minute walk test, that means your patient should be able to stand and walk around. So the purpose that is for baseline. If you are considering maybe baseline, maybe daily progression, then you can use the functional ambulation category. While in the case whereby the patient needs to be discharged maybe from the rehabilitation home or from the hospital to go back home so that the patient should continue on outpatient basis, then you can be able to use the film tool or the 10-meter walk test. So other consideration for the use of this assessment tool is time and resources, because some of the assessment tools might take longer time before you can be able to complete assessment on your patient, and others maybe request limited time for you to be able to assess your patients. For instance, the time up and go. You need just maybe, let's say, within 1 minute, the patient complete the time up and go. Unless maybe if you want to perform maybe multiple trials with your patients, then 1-2 minutes is okay. Other factor to consider if you want to take this assessment tools is the psychometric properties of such tools. So whereby you look at the reliability, validity, and how responsive is that tool in terms of usage in stroke population. So the strategies for mobility after stroke, we have them as in the acute stage, the subacute, and also the chronic stage, of which we are going to look at them individually. So in the acute stage, that is talking about the first 3 weeks. So your goal as a physiotherapist is to, as much as possible, prevent the occurrence of complications, maybe DVT, subluxation within the shoulder, maybe because of the way the patient is being lifted by the family members or the caregivers, or mishandling from the caregivers. So you teach the caregivers as much as possible the way that the patient should be mobilized. You should also maintain integrity within the joints within the individual. You should not have maybe stiffness and other complications that might arise. So at this stage also you can start maybe sensory stimulation. If there is sensory affectation within the individual, you begin it at this very moment. So the training strategies at this the acute stage, we have the positioning and the mobility. This is number one. So the use of maybe pillows to support the individuals. You can use slings maybe to support the shoulder, and then proper positioning of your patient so that you don't have subluxation, or you don't have maybe sometimes you have even dislocation at the shoulder joint. So also you can perform range of motion, maybe passive range of motion within the individual across all the affected joints. Bed mobility is one of the strategies that you can be able to do, maybe a log roll. You encourage the patient to turn maybe from maybe let's say sideline, come into line on the back and come into line on the side. Transfers, you should be able to perform dependent transfers, whereby you can involve 2 or more persons to perform a transfer in your patients, depending on the size of the patients. Sometimes you can use maybe mechanical methods to transfer your patients, especially if your patient is huge or is obese. So introduce the use of a mechanical idea to transfer your patients. And then early sensory stimulation is encouraged. So you encourage weight bearing, especially in upper limb and the lower limb, so that you stimulate the mechanoreceptors and of course the proprioceptors also. So mobilization, this is encouraged also in the early or the acute stage, especially when you have stabilization, other maybe what do you call it? Maybe stabilization, the blood pressure and other vital signs that you can be able to take from the patient. So as much as possible, you start mobilizing the patient out of the bed based on maybe the capacity of your patient. In some acute stage, main essence here is for you to modulate spasticity as much as possible, control spasticity or prevent it from setting in. And then voluntary control is encouraged and is facilitated at this stage also. That is one of your goals as physiotherapists. And you should begin active participation of the stroke person in maybe static postural control and transfers. So tell the patient to sit independent on the bedside, and then you can tell the patient also you can be able to lean sideways, either left or right sides. So this is encouraged at this stage, and it should be your primary focus as physiotherapists. So the strategies that you should consider at this stage of recovery are spasticity management, whereby you position the individual, especially avoiding maybe gravity position, so that gravity will not act on the muscles and the tension or the tonal changes will not happen within the muscle. So maybe if there is spasticity set at this stage, so maybe you can use other methods to do away with the spasticity. So you should introduce techniques that you can be able to inhibit tonal changes or excessive increase in tone. For instance, maybe you can use cryotherapy or other modalities that we can be able to use physiotherapy-wise to inhibit or to manage spasticity. We have the bed mobility and sitting. At this stage, you commence bridging exercises. At initial stage, maybe you can start with giving assistance on the patient. Then you graduate your patient to so that the patient can be able to perform actively. And then this bridging, we all know that it functions to strengthen the lower extremities and of course the trunk, which is mostly not normally considered when we are rehabilitating our stroke patients. We have sitting balance, which is another strategy to consider. At this stage, you start at the edge of the bed, whereby you give some little support to the patient, and then you progress the patient until the patient can be able to perform some some reaches maybe while sitting on the edge of the bed. Maybe sit to spine line. This is also another important factor to consider at this stage. From sitting, your patient should be able to control the trunk and then go back into the spine line position, not maybe an abrupt going back into the spine line. Control sit to spine line. So we have the transfers, assisted maybe pivot transfer. The patient will start to help using the normal side, and then you can use a transfer board if maybe the condition requires that. So you encourage as much as possible nose over the toes, and then you push with the strong arm. For instance, maybe there is a chair with support, and as much as possible, you can ask the patient not to use the sound side. The patient should use the affected side and press on the chair and then come into standing. As much as possible, encourage equal weight bearing, equal weight distribution on either the left side or the right side of the lower limb and also the upper extremities. Early standing, maybe you can begin by the use of the tilt table, or if there is no provision for that, you can use the convenient standing frame if your patient cannot be able to stand alone. So with this, you can be able to progress to maybe assisted standing. You move into the parallel pass. So these are all methods that you can be able to encourage transfer within the stroke survivors. In the late subacute stage, your primary goals are maybe controlling of synergies, and then you improve in the dynamic sitting and also the standing balance. So as much as possible, at this stage, you ensure independence in basic transfers, maybe from, let's say, from going in and out of the car, because the patient is in the late acute subacute stage. So the strategies that you should be able to consider at this stage are the mobility drills, because your patient must have gotten some strength at this stage. Then you teach the patient on how to go out of bed and how to be able to dress himself, maybe after the stroke, the ability to wear his shirts or other form of dress that he or she uses. The sit to stand, this should be your primary goal or primary concern at this stage. So you practice with the appropriate seat level. For instance, maybe you begin from a higher seat and you go to the lower seat. In this case, if you are moving from higher seat to lower seat, you are increasing effort from your patient and you are increasing the complexity of the task. You can use arm support at the initial stage, as talking about maybe sit with arm support, and then you graduate your patients to the use of sit that does not have arm support. So you move into the standing balance. As much as possible, you encourage shifting of weight, maybe side to side or forwards and then backwards. So this is also very essential because it ensures flexibility and movements in all the joints. If your patient can be able to move the affected limb maybe outwards, that's talking about side and then backwards. So this ensures flexibility and adequate movement within such joints. And then the transfer training, you encourage lateral and vertical transfers, maybe from chair to toilet, and then coming back from the toilet to come and sit on the chair, and then bed to chair and vice versa. So you give minimal support at this stage. And then car transfer, so that the individual can be able to drive, maybe especially when the individual is within a car or a vehicle that is automatic. So you encourage going back or integration into the society. And then floor to stand, maybe from the way the individual is right sitting on the floor, the individual should be able to change or transfer position from the floor and then stand up. So gait preparation, maybe you encourage marching. You encourage marching, maybe lifting and dropping of the either left and right lower extremities, the ability to raise the heels, and then stepping over items. For instance, maybe you can bring a boat and ask your patient, okay, lift your affected leg over, place your affected leg over this boat. And also you can do it maybe between the parallel bars or any other items that you feel safe and secured within your patients. So at the chronic stage, This is considered almost maybe the near normal stage. So your concern here is maybe to have refined motor skills, and you should improve endurance and then other safety that are required for your patients to be able to move in the society. And then you should be able to overcome challenges that are within the environment. For instance, maybe modification within the environment, so that the environment will be suitable and comfortable for your patients to be able to navigate around. So these are all very essential when it comes to strategies. Maybe you encourage advanced, maybe you introduce maybe going to ramps so that your patient can walk over ramp surfaces that maybe that will be not convenient for your patients. And then you transfer without maybe the tool or the assistive device that your patient is used to maybe in the environment. For instance, you can tell your patients, okay, I want you to stand up, I want you to sit down, you can raise your walking stick, and then I want you to sit to your bed. So all this, you encourage this at this chronic stage. So gait and advanced mobility, you encourage overground walking. By doing this, you are concentrating your own management or rehabilitation to see that yes, symmetry is ensured within your patients in terms of maybe weight distribution between the left and the right. You encourage heel strike. Why? Because you don't want to have shortening, especially in the TA aspect. You encourage single leg stance. By doing this, you are teaching balance, and of course, you are strengthening also the lower limb. Obstacle negotiation, so that your patient can be able to move around obstacles. You introduce maybe the use of cones in the clinic or in the rehabilitation center. You can use obstacles and ask your patient to move through the obstacles. So by doing that, you are also encouraging movement and transfer within your patient. Another thing to consider is the dual task training. This is very, very important. You can ask your patient to move around while he or she maybe is making phone call, so that you increase the complexity of the task on your patient. Or you can ask your patient, okay, take this, let's say 2 kg of sandbag and move around with this. So doing that, you are also training transfer and mobility within the stroke survival. So we have the task-specific repetitive practice. These are coming maybe in the form of CIMT, mostly maybe for the upper extremities, especially maybe when all things are normal, that the patient can be able to perform the CIMT. You can also perform treadmill training, maybe with or without the body weight support. You can begin also circuit training at this stage by maybe using train stations for STS, maybe step-offs, and then walking around, and then and other aspects of specific training. So the take-home messages from this presentation is that we all know that, like we have seen in epidemiology, stroke is always increasing by day, or I can say by hour. Every hour or every second, we tend to have occurrence of stroke. So we need to have an efficient mobility and transfer strategies, so that we can be able to help our patients, and then they can be able to engage in other activities within the society. We should know that also mobilization early should be instituted as much as possible. If the vital signs are stable, then begin mobilizing your patients. Mobilization does not entail, okay, start walking around. No, we have seen it in the previous slides. That the mobilization can be just maybe through performing passive mobilization on your patient, or maybe sitting the patient upright on the patient, on the bed rather. Maybe you can just tilt the head of the bed so that your patient will assume sitting position. By doing that, also you are mobilizing your patient. So we should also know that caregivers and the family members of the victims or the stroke survivors, they are also important components. for the care, because mostly if you don't involve them, you will not achieve what you want to achieve in your patients. At some point, the family and caregivers, they are considered as the most integral individuals in the rehabilitation. So if you want to have a successful rehabilitation, involve the family and the caregivers. Always teach them the do's and the don'ts that you want in your patients, and then you can have successful rehabilitation. So the last point is intensive and consistent and important practice is normally essential at each stage of maybe the recovery after the stroke. This is to optimize functional independence and also ensure neuroplasticity within our patients. So thank you. And this comes to the end of the presentation. Thank you everyone for listening.
Thank you very much, sir, for such a wonderful, comprehensive presentation. The floor is open for questions and answers. Anybody who has a question is free to ask.
Hello. Good evening, sir. Please, I have a question. Can I go on?
Hello. Good evening.
Yes, sir.
Yes, go ahead.
Thank you very much, sir. Presentation. It's such an educative one. And you have opened, especially mine, let me speak for myself. You have opened my mind to a lot of things that I haven't learned before, especially with regards to the outcome measures and then the transfer procedures. So my question is regarding some of the complications that occur, especially due to transfer, probably before the physiotherapist is invited to join the team of the rehabilitation. With regards to subluxation, especially probably ankle sprain and then maybe the ankle joint subluxation. So in that instance, I believe that is going to kind of either delay the, let me say, the time it will get to achieve the goal of the treatment. If we have such case, what is the best way to do? Because as you said now, requiring the patient to transfer is one of the procedure we should inculcate in the acute phase. Then this person is now having subluxation at the ankle, which might hinder the standing of the patient at that time, probably due to pain or even being afraid of the instability of the joint. So what can be done in this stage if that arises? Thank you very much, sir.
Okay, thank you for the question. So the best thing, as I said, prevention is better than cure. So the best thing is to prevent the occurrence of the subluxation at the ankle joints. That is number one. And if it has happened, so it will deter you or prevent the patient from maybe bearing weight on such limb, most especially if the limb is the affected limb. So that means weight bearing will be minimal or will be none on that limb, particular limb. So in that case, in physiotherapy, you can use your own modality based on the assessment that you must have performed on the ankle. You can use other modalities to first manage associated maybe presentations at the ankle. For instance, maybe there is pain, like you have mentioned. Maybe there is associated swelling, there is loss of function. So use your own knowledge and then plan accordingly, and then you manage the patient. Alternatively, if maybe you are in the neuro group and maybe you feel that, okay, you are limited in management of such patients, in areas whereby you have multi-speciality within the physiotherapy domain, you can be able to invite your other colleagues, maybe from maybe the orthopedic or musculoskeletal physical therapy, so that they can come and they can assist you in the management of that either subluxation or other condition that is happening within the ankle joint. And you can use other devices also, maybe so that you can offload the ankle joint. So I hope I've answered your question.
Yes, thank you very much, sir. Thank you, sir.
Thank you.
Hello, Assalamu alaikum. Assalamu alaikum, sir.
Walaikum assalam.
Sir, please, I have
Walaikum
a
assalam.
question. Thank you very much for your wonderful presentation. Please, my question is that there is a hospital that I know, one of the physiotherapists who always capitalize on ambulating a patient immediately after the patient had a stroke. That's at acute stage. He always emphasized that a stroke patient should not be, you should not ambulate the patient or stand the patient immediately after the patient had the condition. So, sir, please, I would like you to shed more light on the maybe relationship between weight bearing at I'm talking about the lower limbs, weight bearing on lower limb immediately after stroke, because he always capitalized that the patient can have hyperextension. His fear is always that the patient will have hyperextension when he is ambulated or when you stand the patient at acute stage. Please, I would like you to, if you can please talk on that. Thank you, sir.
Okay. Okay. Thank you for raising this important point, because sometimes we have our patients in our minds, and we tend to have that what should I call it? Let me say aggressive mind, so that we see quick recovery in our patients. And we know that neurological conditions, it takes time before it can recover. It's unlike other conditions. So weight bearing does not necessarily mean the patient should stand on the limb. Based on our slides, you can see that maybe the patient can begin weight bearing right from the bed, right from maybe the time that the patient does not have maybe power in maybe the affected limbs. You can assist the patient to perform breathing while the patient is on bed. You can also assist your patient to perform maybe sitting on the bed and bear weight on affected upper extremity. So those are very essential when it comes to managing your patient. However, maybe ambulation is different, is not so to say weight bearing that you have mentioned earlier. Ambulation means the patient should walk around. So there are components that are important. One is power in the lower extremity. This is very important, because if the patient does not have power in the lower extremity, then you should not expect such patients to be able to walk around. So that maybe at the end, you shouldn't come and have other complications, because let's say maybe the muscle power there is at the flaccid stage, whereby at the flaccid stage, we know that you can subject your patients maybe to injuries. Maybe the joints are laxed because there is no contraction from the musculature, maybe to inhibit unwanted movements. So you can end up having injuries to your patient instead of maybe the patient becoming ambulant. So the most important thing is that you stimulate and you encourage or you restore power in such lower extremity first, and then you begin ambulating your patient. There are some level of stages that is not encouraged. For instance, maybe if the power is 0, you cannot walk the patient around. But however, you can mobilize the patient, maybe from, let's say, lying position to come to sitting position, and the patient can come out of the bed, or you can use a tilt table if maybe there is such facility in your work environment. You can use tilt table so that awareness of the patient, you are changing the entire awareness of the patient, and also other apparatus that are required for maybe the postural control in the patient. By doing that, we are stimulating them also. So this is my take based on that scenario. Thank you.
Thank you very much.
Thank you.
Sorry, sir. Excuse me, sir. Thank you. I'm back again. It's just regarding the question that my senior colleague just asked now and response. So I want to be clarified on something, because when you were mentioning the affectation with regards to stroke, I mean, even from the class, what we have learned is that, okay, it's probably the control center from the brain that is being affected, and then the limb. I mean, let's say the peripheral aspect of the limb, talking about the muscle itself, the integrity of the muscles, they are fine, if not for the somatosensory aspects, and then some of the tracts that have been affected. So should we still categorize the loss of voluntary control, or let me say the loss of the ability to perform tasks in stroke survivors? Should we still consider it as probably a weakness or loss of power with regards to the activity? Or we should say that probably what they are having is loss of voluntary control of that particular affected side? That's number one, sir. Then number two, with regards to the transfer, like some of the outcome measures that you have mentioned, in the acute phase, probably the TUG, the 10-minute walk test, and the rest. For a patient that can actually, let me say, stand, but not without support or assistance, probably they need some kind of assistive aid, be it the walking frame or the quadruped or the walking cane. If we are to use these outcomes, are we meant to use the outcomes with the patients using such assistive aid, or rather we wait until the patient is able to probably ambulate with little or no support, or let me even say no support at all? That is when we can subject them to such outcomes. Thank you very much.
Okay, thank you. This is vital questions. So let me start responding from the second one. That's talking about maybe let's say the 10-meter walk test. So sometimes if the patient is using an assistive device, for instance, let's say maybe a walking aid, let's say a walking stick, so that will not stop you from the patient to perform, let's say, the time of go test or the 10-meter walk test. The patient should be able to perform the 10-meter walk test maybe with the walking stick. And the most important thing is for the patient to cover such distance, because the device is just assisting the patient to move around. The patient works with the two lower extremities. The device or the walking cane is just there serving as assistance. Hope you get my point. Then the second aspect is the first question, talking about the voluntary control. So there is sometimes there is loss of voluntary control and there is reduction in voluntary control. That's when you are talking about the power within the individual. So the voluntary control requires a lot of things. Voluntary control may be ability for you to maintain, let's say, an upright and erect posture so that you can be able to stand without maybe tilting either to the side or to the other side. So in that case, you need power. The power should not come only from the limbs. You need power also in the trunk musculature. So that's why if you are dealing or attending to a stroke patient, it is always encouraged that you should also strengthen the trunk so that you have symmetry also within the trunk muscle. And when you have symmetry, that means you have a balance of maybe strength within the trunk musculature. And as much as possible, you look at other factors that maybe can cause affectation in the postural maybe symmetry. For instance, maybe there is low back pain, or there are other maybe musculoskeletal conditions that that the patient is having. So these are all, that's why it is important if you are assessing your patient, you assess your patient from head to toe. You don't only look at maybe the physical impairments or maybe the patient suffered from stroke. Okay, I will only assess the upper limb and the lower limb. No, you should look at other, what do you call it, other over affectation that the patient is having. So that's when it makes your rehabilitation process to be smooth as possible. Thank you.
Okay, in the absence of, there are no other questions? In the absence of any further question, we'd like to greatly appreciate your presentation, Professor Sir. It was comprehensive, insightful, and perfectly timed. Thank you for sharing your expertise, sir. We are very grateful.
Okay, thank you, Dr. Naima. Yeah, thank you, Dr. Naima, NSP Kano State, and entire participants for sparing the time to be together with us, and then share knowledge and ideas to see that our patients recover and without other maybe unwanted manifestations. At this point, I appreciate everyone for giving me the opportunity to talk on the topic. Thank you.
Thank you, sir.